not only I'm part Egyptian, but I'm now part Arab also.
Arab, yes,
from,
yes.
From
You
Abu
became,
Dhabi.
you became United Nation.
Right. Can you hear me on the back? Or maybe I should ask, can you see me on the back? I'm so short that I'm hiding behind the podium. So hopefully you can see me and hear me. I apologize for this change in the title of my talk. I was invited just a few days ago, and my schedule did not permit me to do justice to the published topic. So I'm going to talk to you about very important topic, I think, and that is rapid on-site cytological examination. Rapid on-site cytological examination pertaining to TBNA. However, it could be utilized in all bronchoscopic specimen you collect. So this is more commonly known as rapid on-site cytological examination. So ROSE, that's what I'm going to talk to you about. So what is the basis for rapid on-site cytological examination? What I'm talking about is that you bring the cytopathologist in the bronchoscopy suite, and he would look at the specimen right away. As soon as you obtain the specimen, he or she is going to look at that particular specimen, give you the answer, and that is rapid on-site cytological examination. And what is the basis for that? And the basis for this thing is, again, if you give me a better pointer, I would really enjoy it. Okay, could you get me another one? Okay, so the basis for ROSE is the principal cause for non-diagnostic negative specimen is an inadequate specimen. You send it to the cytopathologist and say it is negative because there is not enough material for me to give you comments on. And if you can eliminate that, you can reduce the number of negative cytological specimens. So, principal cause of non-diagnostic negative specimen is inadequate specimen, one that contains only mucus, respiratory epithelium, or blood. Instant on-site examination may eliminate the obstacle. Just to show you for an example, this is a TBNA specimen, but it is all full of respiratory epithelial cells, and it is not a good specimen. So cytopathologists would instantaneously tell you that you need to provide me with more specimen, not the next day, the same time the bronchoscopy is being performed. That is rapid on-site cytological examination. Okay. So once again, what is the importance? What is the basis? And let me show you the importance based on this particular study. Very interesting study. Look at the very recent study here, 2010. 187 mediastinal and hilar lymph nodes were aspirated with transbronchial needle aspiration. 7-year experience, as you see it here. There were 21%, 22% negative or inadequate samples. So when you do procedures like transbronchial needle aspiration and even brushing at times and endobronchial biopsies, as many as 22% of your specimen will have inadequate material that cytopathologists cannot comment on. And a very simple thing, that if you do not look at those samples for malignancy, suddenly you increase the diagnostic yield and sensitivity and accuracy of flexible bronchoscopy or transbronchial needle aspiration to 88%. What I'm trying to say, that if you eliminate this 22% of inadequate specimen, you can do much better with your flexible bronchoscopy. So if you have that luxury of inviting your cytopathologist in the bronch suite, you will be a better bronchoscopist. That is my message today to you. So now, this is all institution or geography dependent. What different ways you can do rapid on-site cytological examination or ROSE. Immediate cytological examination is also another term for that. That is referred as ICE. ICE or ROSE are the two common terms utilized to describe rapid on-site cytological examination. Several different stains or methods can be used. Most commonly used is Quick method, which is a trade name for a cytological examination, and this particular exam is performed in seconds. It takes only a few seconds to carry out this particular examination. You can also use Roux method. It is a right stain method. It takes 90 seconds. You can also use very simple Toluidine blue, which gives you result in few seconds. H&E stains can also be used for rapid on-site cytological examination. And of course, very commonly used, very famous Pepinicola stain would give you results in about 3 minutes if it is used for rapid on-site cytological examination. The reason it gives you good results, it provides superior chromatin and cytoplasmic staining. Exam is carried out either by cytotechs, technicians, pathology fellows, if you have fellowship programs, by a pulmonologist themselves, or by pulmonary fellows, or by e-pathology. What do I mean by that? You prepare the specimen, or your assistant prepares the specimen, and the specimen is televised, or it is transmitted to the pathology lab, so pathologist does not have to come to the bronch suite. They can just look this thing on the television monitor and give you the results that you need to do more specimens. Okay? So these are several ways to do. And if you're a good pathologist yourself, you can increase your diagnostic yield, and a variety of specimens are tested. What I'm talking about is not only TBNA specimen, but the brushing, percutaneous needle aspiration, all those type of specimens can be looked under rapid on-site cytological examination. A pathologist or cytologist would walk in with a cart, and this cart contains this diff quick stain system, or all the utensils required for that. Fixative solution, solution 1, solution 2, and distilled water. As I mentioned to you, this particular test just takes few seconds to get you the diagnosis of rapid on-site cytological examination. Dry tap, dry method, only the air spray from the TBNA needle is placed on the slide, smeared in this particular fashion, and placed into the diff quick smear stains to give you the diagnosis. I will not take you to the entire laundry list of how do different blood cells look like with rapid on-site cytological examination, but just to show you that this is adenocarcinoma, this is a metastatic breast cancer to the lung, this is how it looks on rapid on-site cytological examination. Within few seconds, patient will have diagnosis of your bronchoscopy. Okay, now, let me take you to the world's literature on rapid on-site cytological examination for TBNA. Rose for TBNA. Who started all this business? Dr. Davenport. He was very much interested in looking into the benefits of Rose for TBNA. It was already being used for percutaneous needle aspirations and so on and so forth. His retrospective analysis over the period of 3 years, 207 patients, 207 lymph nodes, 161 patients, they had conventional bronchoscopy in 134, and 73 patients underwent rapid on-site cytological examination. Both groups had comparable prevalence of cancer, technique was equally the same, location of the lymph node was same, and they just used Toluidine blue to do rapid on-site cytological examination, and voila, you see what is a big difference on this particular study. Dry tap, I already mentioned to you, inadequate negative specimen. Look at the numbers. It reduced from 56% to 17%. So inadequate specimen number reduced significantly, and hence diagnostic yield improved or doubled from 31% to 56%. If you have this luxury in your hospital that cytopathologist is ready to come to the bronch suite, use that particular luxury, you will be a better bronchoscopist in this particular fashion. It improved the diagnostic yield, it reduced the number of aspirates required, it improved the negative predictive value of bronchoscopy. Rose also diagnosed benign conditions such as amyloidosis and granulomas. So once again, rapid on-site cytological examination increases diagnostic yield of flexible bronchoscopy. Next article, and I'm taking it in a chronological order. This was published in American Review in 1996. It was placebo. It was a prospective randomized control study. What they did, EBUS. This is a radial probe EBUS, transbronchial needle aspiration versus transbronchial needle aspiration with Rose. They did radial probe EBUS and TBNA, they did that, or TBNA with Rose. So they compared conventional with a fancy tool of radial probe, 82 bronchoscopies in 80 patients. Sensitivity of using Rose, EBUS conventional was 82%, diagnostic accuracy of EBUS versus convention, let me take you through again. Looking at the sensitivity, radial probe EBUS versus conventional Rose, conventional TBNA with Rose, it had higher yield here, or higher sensitivity, and diagnostic accuracy was also higher. Number of aspirates were lower for EBUS, but not for carcinoma or subcarinal lymph nodes. TBNA with Rose has similar yield as compared to radial probe EBUS for mediastinal nodes. EBUS reduces the number of aspirates for smaller lymph nodes in difficult location. What I'm trying to say is this, that if you do not have a radial probe ultrasound, but you have a cytopathologist who is ready to come to your bronch suite, you can match the results of radial probe ultrasound in this particular fashion. Okay, that is the point I'm trying to make with this particular article, which was prospective, randomized, and controlled trial. Okay? Now, once again, the next article, I'm taking you now to year 2000. Utility of Rose for bronchoscopic evaluation of lung masses and adenopathy. Aim was to establish association between on-site assessment and diagnostic success during this period, about 1 year time. 204 flexible bronchoscopies were performed. Yield was similar for the masses versus lymph nodes. Malignancy, as it is shown here, out of 127 in 94 patients, and other diagnoses such as TB, fungal infection, sarcoid, BOOP, and bronchogenic cyst were diagnosed in this fashion. Let me show you what happened with the Rose. 81 or 40% of the patients underwent transbronchial rapid on-site cytological examination. TBNA yield 54, bronchoscope endobronchial biopsy of proximal lesions 15, bronchoscopic biopsy of distal lesions in 30%, and transbronchial biopsy was performed in 35% of the patients. Number of TBNA aspirate, as you see here, in conventional versus Rose. Rose had higher number of biopsies performed as compared to conventional. However, diagnostic yield of Rose was 81% versus 50% convention. 40% increase in diagnostic yield when rapid on-site cytological examination used, and the odds ratio of making the diagnosis improves by 4.5-fold. Discordant trends, point I'm trying to make, when you do rapid on-site cytological examination, there is about 13% discordance rate according to this one particular study, where cytopathologists later on may change the diagnosis in some of your patients. Just for United States, it is not reimbursed as frozen sections, so there is no financial benefit of doing this thing. However, you can increase the diagnostic of the flexible bronchoscopy in this fashion. Okay, another study which was published not too long ago, 50 patients prospectively looked at mediastinal lymph node enlargement. Diagnostic yield was 74%, and as you can see here, the various different type of cancers were present. Benign conditions were also present. Lymphomas were also present. And in 18 patients, they found there was lymphocytic hyperplasia was also there, that was diagnosed by transbronchial needle aspiration and rapid on-site cytological examination, increasing the negative predictive value of this particular technique. How many aspirates? This is a very interesting study. I'm sure all of you are familiar with who do bronchoscopy every day. Dr. Shen wanted to look at, his purpose was that how many aspirates are required to make the diagnosis. So he kept on looking at diagnostic yield in every specimen he collected, 1, 2, 3, 4, 5, 6. That was the purpose of this prospective open label study. However, he also used Rose, or rapid on-site cytological examination, in his patients. And as you can see, that when Rose was performed in 55, that is 70% of his patients, it increased the diagnostic yield from 25% to 71%. You could be a better bronchoscopist if you use rapid on-site cytological examination, and that is the purpose of this particular study. That was a fringe benefit or the secondary outcome in this particular study by using ROSE. This is one of the largest and most defined study done looking at the ROSE and TBNA. My friend Dr. Chris Bolliger from South Africa, he looked at rapid on-site cytological examination on TBNA in 90 patients. TBNA was performed in 162 patients under local anesthesia and conscious sedation. I bring that thing out because you don't need to use general anesthesia and rigid bronchoscopy to use ultrasound-related transbronchial needle aspiration, as it is shown in some studies. They had a procedural algorithm that what would they do if TBNA is negative, what tests they would do. They had algorithm. Time commitment for bronch personnel was also closely monitored. The final diagnosis was achieved in 78%. It was malignancy, benign diagnosis in about 18%, and unknown in about 4 to 5%. Pathologists were blinded to the ROSE diagnosis as well. So they looked at final diagnosis after ROSE was carried out. Diagnostic hill in malignancy 77%, benign conditions 25%. As you see here, let me take you through the entire process here. Sensitivity of TBNA using ROSE was 96%, negative predictive value was 93%, and positive predictive value was 98%, as shown by Dr. Bolliger in this particular study. Because of the time, I will not take you to the entire detail, but accuracy of ROSE TBNA is pointed out to you here in this particular line underneath the slide. 59 of 66 patients were diagnostic when ROSE was used in this particular group in a prospective fashion with ROSE TBNA. So impact of ROSE in this particular study was they detected diagnostic material at first time. You put the first needle, and 50% of the time you say you don't need to do any other tests during bronchoscopy. Termination of flexible bronchoscopy after TBNA in 64% of the cases. Assisted in adjusting sampling strategy in 5 patients with tuberculosis or sarcoid. ROSE TBNA contributed in 71% of all flexible bronchoscopy. Once again, let me repeat what I have said about 3 times. If you use ROSE, rapid on-site cytological examination, it would make you a better bronchoscopist. Need to perform a forceps biopsy reduced from 65 to 18% in his study. Is my time up? Is it okay? Time is okay? 2 minutes. I'll be done in 2 minutes, okay? I'll be done in 15, right. Okay, time log for bronchoscopy personnel. They also looked at how much time an individual is spending when you do transbronchial needle aspiration. As you can see, bronchoscopist time, theater nurse time, cytology technician time, and administrator's time was all reduced, except pathologist had to walk from his office to the bronch suite, and 12 minutes was the walk time and 5 minutes was the procedure time. Cost, if you talk about the cost, as you can see, per procedure, Dr. Bolliger saved 25 rands. In South Africa, the currency is rands. Per procedure, he was saving 25 rands by saving all the equipment in this particular fashion, besides saving significant time. Very quickly, let me just finish. TBNA with ROSE, as it is shown in this particular study, which was published in 2003. TBNA with ROSE, 45 patient, consecutive patient. Diff-quick method was used. Diagnostical 65% for mediastinal disease for both benign and malignant disease, and diagnostic utility was 71%. Besides just doing simple TBNA, you can add or you can use ROSE for other things as well. Dr. Gasparini, my friend, what he does bronchoscopy, he does rapid on-site cytological examination of TBNA. If all his specimens are negative, he himself is a cytopathologist. If everything is negative, he turns the patient over, and during the same sitting, he would do percutaneous needle aspiration for pulmonary nodules. So he used ROSE, he uses ROSE for his algorithm here, and you will show that his diagnostic yield sensitivity of 95%, integration of ROSE in diagnostic work of a pulmonary nodule. When you do all these things together, he's 95% successful in this particular fashion. And this is his study when he combines this thing, transbronchial biopsy, TBNA, transbronchial biopsy plus TBNA, percutaneous needle aspiration. overall diagnostic yield, in that succession, he achieves 95%. Dr. Gaspertet, he used CT fluoroscopy and ROSE, and once again increased his diagnostic yield significantly. ROSE helped to reduce procedure time and radiation exposure and provided high diagnostic yield when ROSE was used as CT fluoroscopy. So let me summarize what I have said is that it significantly reduces duration of the procedure, number of results of each passes, and so on and so forth. So let me, for the time's sake, I'm not going to take you through this particular study, but ROSE improves diagnostic yield, sensitivity, specificity, and diagnostic accuracy of TBNA, as well as bronchoscopy, overall bronchoscopy. So let me show you my last slide. ROSE TBNA, negative or equivocal finding addressed instantaneously with repeat aspiration of the same site, which happens with ROSE. It improves site selection. It improves the technique. It avoids random number of aspirates we obtain. Minute TBNA samples are handled optimally and with more precision. On-site analysis is cost-effective. ROSE TBNA is highly useful, accurate, and a cost-effective addition to routine diagnostic procedure. And in my view, rapid on-site cytological examination is poor man's endobronchial ultrasound. If you don't have money to buy this thing, if you apply this particular tool, you will improve your diagnostic yield significantly. Thank you very much, and I appreciate your time.
Thank you, Dr. Professor Mehta, for his valuable talk, and he learned us about what is better for doing TBNA and how to do cytology for it. Now we will invite Professor Dr. Khalid Kamel to deliver a talk about EBUS. Dr. Khalid is a professor of chest in Cairo University, and he is my colleague in intervention bronchoscopy, but he is one of the best in EBUS and in bronchoscopy, and he is one of the discipline professors in our department for his work, and he is best for EBUS, and he will
انا زعلان من اسكندريه والله العظيم وحياة ربنا انت وفرت اكبر سنه انت كنت معرفش الفلوس عندكم قليله ولا ايه؟ اشمعنى انا شويه رحاب ولا بتاع عشان اتجوز
السلام عليكم. بسم الله الرحمن الرحيم. Endobronchial ultrasonography. Endobronchial ultrasonography is a procedure in which the physician uses ultrasound device inside the airways for exploration of the structure of airway walls and the surrounding extrabronchial structures. This is the ultrasound set present in Qasr Al Ain Hospital. This is the ultrasound processor, the controlling keyboard. This is the probe of the ultrasound introduced through the bronchoscope. There are two types of endobronchial ultrasound probe. The first one, radial scaling probe. Its a frequency 20 megahertz. It is a miniaturized catheter probe that bearing a mechanical transducer at its tip that rotates 360 degrees and provides a sectional view into bronchial wall and extrabronchial structure perpendicular to the probe. This is a radial scanning probe. في two sizes. الأوتر diameter بتاع first one 2.5 millimeter, second one 1.7 millimeter. The first one is used for exploration of central lesions by balloon contact technique through insertion through balloon sheath, which is inflated with water. While during direct contact technique, the probe used alone without the balloon sheath, and this is the image, the probe present at the center, like end-on probe, directly in contact with the surrounding tissues. While during in balloon contact technique, there is an anechoic circle around the probe, which represents the water-filled balloon. The another probe type, convex probe, its frequency 7.5 megahertz. It is ultrasonic endoscope with an electronic curvilinear scanner at its tip, which provides a sectional view into the bronchial wall and the mediastinal structure parallel to the probe. The probe at the tip of the bronchoscope, we can inflate a balloon around the probe, and the working channel is angulated. We can introduce a needle through it for real-time endobronchial ultrasound guided TPNA. Here the sectional view, it is parallel to the probe in the bronchoscope. Role of endobronchial ultrasound, we can examine the mediastinum, we can examine the bronchial wall, we can examine the lung parenchyma. In the mediastinum, it is used for assessment of mediastinal and higher lymph node, check for invasion of great vessels by tumor tissue. In the bronchial wall, detect the depth of bronchial wall invasion in early lung cancer, differentiation between airway infiltration and the compression by tumor tissue, and in lung parenchyma, study of peripheral lung lesion, and EPAS-guided biopsy from the peripheral lung shadow. This case presentation from our department, from the fiber optic bronchoscope unit, chest department, Cairo University. The first case presenting with dry irritative cough, chest X-ray revealed bilateral hilar shadow. CT chest, there is bilateral hilar and subcarinal lymph node enlargement. EPAS by direct contact technique at the ridge between the right upper lobe and the intermediate bronchus reveals presence of two enlarged lymph node, and the EPAS-guided TPNA revealed Hodgkin lymphoma. This case presenting with hemoptysis, this is X-ray, increased bronchovascular markings. There is a small shadow in the left upper lung zone. The CT chest revealed the nodule present in the left upper lobe. There is no sizable or detected mediastinal lymphadenopathy. This is the pulmonary window, the lesion present in the posterior segment of the left upper lobe. This is the EPAS by direct contact technique at the ridge between the left upper lobe and the lower lobe. By direct contact technique, revealed the presence of lymph node enlargement. And the EPAS-guided transbronchial lung biopsy from the peripheral lesion and the EPAS-guided TPNA from the left hilum revealed that this case is left upper lobe adenocarcinoma with left higher lymph node metastasis. So EPAS is very important for staging of bronchogenic carcinoma. Next case, this presenting with dry irritative cough and dyspnea. There is pretracheal retrocaval lymph node, subcarinal lymph node, and right hilar lymph node enlargement. In the pulmonary window, there is bilateral pulmonary infiltrates, particularly in the right lung. Fiber optic bronchoscope revealed subcarinal widening, and the EPAS by direct contact technique at the main carina revealed the presence of enlarged lymph node with intact bronchial wall as all layers were intact. At the ridge between the right upper lobe and the intermediate bronchus, also there is a large lymph node. The orifice of the right upper lobe showed a reddish spot, which was positive with autofluorescence study, and the EPAS by direct technique at this site revealed destruction of the layers of the bronchial wall cartilage, of the bronchial wall, particularly the layers of the cartilage, which denote presence of bronchial wall invasion. So the layers of the bronchial wall is very important to differentiate between bronchial wall compression versus inflation. If there is destruction to the bronchial wall layers, particularly the cartilaginous layer, this is bronchial wall invasion. EBUS-guided TPNA reveals that case of low-grade B-cell lymphoma. In the peripheral lung shadow, this is a normal lung parenchyma. With EBUS, the probe in the center surrounded by hyperechogenic fading out shadow, which representing the air present in the normal alveoli, and besides there is a small hypoechogenic circle which is pulsating during layer time ultrasound examination, this presenting the accompanying pulmonary arteriole. In the peripheral shadow, we comment about 4 criteria selected to differentiate between neoplastic and non-neoplastic lesions. The first one, hyperechogenic margin outside, the internal echo pattern, presence of patent blood vessels, airways, concentric circles around the probe. For example, hyperechogenic margin, this is example for hyperechogenic margin around the lesion. Here there is no hyperechogenic margin. The presence of hyperechogenic margin is more common with neoplastic diseases. Internal echo, this is homogeneous pattern, this is heterogeneous pattern. Heterogeneous pattern is more common with neoplastic lesions. Patent blood vessels, here there is a patent blood vessels and patent air bronchogram. The blood vessels appear as circle of hypoechogenic shadow and it is pulsating, while the air bronchogram appears as hyperechogenic dots with distal ghost shadow. Here there is no patent blood vessels or air bronchogram, and the absence of blood vessels or bronchogram is a more common with neoplastic lesion. Concentric circles around the probe. Here the bright dots of the ultrasound are arranged in circles around the probe. Here there is absence of this arrangement, and the absence of concentric circles around the probe is more common with neoplastic lesions. This case presented with fever, cough, and expectoration. Chest X-ray revealed a shadow opacity present in the right lower lung zone. CT revealed consolidation of air bronchogram, middle lobe pneumonia. This is EBUS shadow, multiple patent air bronchogram and blood vessels. This is non-neoplastic lesions, reach of patent blood vessels, and this case of middle lobe pneumonia. This case presenting with hemoptysis, there is a lesion present in the right lower lung zone. CT revealed the lesion with pleural reaction. This is the pulmonary window. The lesion present in the anterior segment of the right lower lobe. EBUS revealed the lesion with hyperechogenic margin with absence of patent blood vessels and air bronchogram. And EBUS-guided transbronchial lung biopsy revealed poor differentiated adenocarcinoma grade 3. This is another case, presence with cough and expectoration. Chest X-ray revealed hyperinflation. CT chest just hyperinflation signs and small nodule in the left upper lobe. This is the lesion. It is speculated. It is difficult to reach by CT-guided biopsy as it is present under the scapula. So EBUS can get the site of the lesion, and the EBUS-guided transbronchial lung biopsy revealed grade 2 adenocarcinoma. In the bronchial wall, this case present with cough and expectoration, normal chest X-ray, fiber optic bronchoscope revealed 2 reddish spots at the ridge between lingula and left upper lobe proper. By autofluorescence, there is cold spot. By EBUS, there is thickening in the bronchial wall and destruction of the normal layers of the bronchial wall. In this case, this is called extracartilaginous lesion due to destruction of the cartilaginous layer. While if the lesion respects the cartilage and does not invade the cartilage, this is intracartilaginous lesion. It is important to differentiate in early lung cancer which it is intracartilaginous or extracartilaginous, because intracartilaginous we can treat with endobronchial therapeutic modalities with curative intent like laser or argon plasma coagulation. Last case presenting with recurrent attacks of massive hemoptysis. Plain chest X-ray, PA and lateral were free. CT chest was free apart from post-hemoptoid effect at the right lower lobe. Fiber optic bronchoscope revealed presence of patch of redness present at the medial wall of the middle lobe. It was positive at autofluorescence due to presence of blood. And fiber EBUS by direct contact technique revealed the presence of thickening at the bronchial wall and structure of the normal layers of the bronchial wall, which occupied by a hypoechogenic loculi with hyperechogenic margin. And due to the massive attack of hemoptysis, the patient had lower middle lobe lobectomy, which revealed the presence of bronchial wall angioma. EBUS is important, so EBUS is important for study of the mediastinal lymph node and staging of bronchogenic carcinoma, assessment of early lung cancer for endobronchial therapy, differentiation between bronchial wall compression and invasion, and guided biopsy from peripheral lung lesion. Thank you.
Thank you. Thank you very much, Professor Khalid Kamal, about this elegant talk about the value of EBUS, especially if combined with other modalities like SAFE in diagnosis and assessment of peripheral and mediastinal lesions, as well as assessment of operability and staging of lung cancer. Now I'm going to introduce my dear colleague and one of the eminent experts in the field of intervention bronchoscopy, Professor Ahmed Qura'a. We'll speak about electrocautery in central airway obstruction. الصورة دي معبرة جدا يا دكتور عماد.
دي
اتعلمنا عليها بس.
من دراكولا.
عايزين كومنت على الصورة دي.
Thank you, Mr. Chairman. We're going to talk about the electrocautery in endobronchial electrocautery in general. Electrosurgery, electrotherapy, electrodesiccations, electrocoagulation, electrosection, and surgical diathermy are other terms appearing in the literatures in addition to the electrocautery itself. It started in 1926. The initial report on electrocautery for tracheobronchial tumors was published by Vinson and Boeing. They described the basic concept and technique using musical wire wrapped in a rubber tube as the probe and applying therapy through rigid bronchoscopy. In 1930s, several reports on endobronchial electrocautery were published, including one describing its outpatient use. However, complications such as burns, shocks, tracheal perforations, and fatal hemoptysis dampened enthusiasm for the technique. In 1980s, a renewed interest in the technique appeared with the refinements of the electrode and other hardware and the use of more sophisticated generators of high-frequency current, which improve the efficacy and safety in bronchoscopic electrocautery. Electrocautery uses alternating current of high frequency to generate heat, which coagulates, vaporizes, and or cuts tissue, depending on the power, measures in watts. Coagulation involves high amperage and low voltage, whereas vaporization uses high voltage and low amperage. So always remind you by the V of vaporizing and the voltage, the high voltage. At 70 degrees, tissue coagulates, and over 200 degrees centigrade, tissue carbonizes. Contrary to cryotherapy, greater tissue damage occurs with only small contact area. Now let's see the effect of electrocautery on biological tissue. Now with applying the normal electric current to the biological tissue, this will induce electrolytic effect, capacitance effect, and thermal effect. However, with applying the high frequency current, only the thermic effect will be left that will lead to coagulation and or cutting. Most electrocautery devices are monopolar. That means they require the patient to be grounded to complete the circuit. If this grounding is not done, shocks, burns can happen. Also, the patient must not contact any metal while undergoing electrocautery. The preoperative patient evaluation monitoring procedures are the same as those for fiber optic bronchoscopy. Now for the technique, the operator can use either a closed forceps, as we may see, or a probe, or the blunt probe, as we may see in this photo, to manipulate the lesion, to assess its size, mobility, friability, and bleeding potential, this before applying the electrocautery to the tissue, and to locate any attachment to the airway. Elongated or flat lesions may be suited for the blunt probe, whereas the polypoid lesions may be amenable for the snare. The probe is placed into contact to the tissue so that blanching occurs to be sure that the probe is in contact to the lesion I wanted to cauterize. The generator then is activated. However, the snare, as appears in this picture, is used to cut and remove tissue. With the loop open, the snare is placed over the tissue and closed to the base, close to the base as possible. As the loop is tightened, the unit is activated. In this fashion, the heat, not the mechanical effect of the snare, cuts and coagulates the tissues. Now for the argon plasma coagulator, is also available for electrocautery coagulation with no tissue contact occurs. Ionized argon gas serves as the current conductor between the probe and the tissue. However, it is not as efficient in removing endobronchial tumor as the electrocautery or the NDIAG laser. Also, the depth of penetration of the APC, the argon plasma coagulator, is approximately 2 to 3 millimeter only. And it has been reported that approximately 5 patients have had temporary neurological impairment caused by air embolism after the APC application. This chest X-ray shows a case of adenocarcinoma with complete collapse of the left lung, and this is a picture showing recanalization of the bronchi post-cautery. And this is another case with non-small cell lung cancer with a tumor mass completely obstructing the right main bronchus, and this is the post-cautery view image with complete successful canalization of the right main bronchus. This is the same X-ray for this patient. Now for the indications of the electrocautery is palliative debulking of the endobronchial exophytic lesions and treatment of benign endobronchial tumors and or of iatrogenic or post-infectious cicatricial stenosis, and also the potential cure of visible superficial lung cancer as severe dysplasia to microinvasive carcinoma. The indication of the electrocautery, only laser resection and electrocautery produce rapid tissue destruction in a single setting and can therefore appropriate to treat lesions that are producing acute respiratory distress or hemopsis. The NDIAG laser generally is used in this situation, but expenses limit the availability of laser equipment in many parts of the world. The electrocautery is called the poor man's laser. This is the price of the laser in the USA. I don't know if it still exists or not. I'll tell this figure in Egyptian pounds. The electrocautery, it costs about 100,000 Egyptian pounds. However, the laser machine costs about 400,000 Egyptian pounds. You may see the difference, 4 times as that for the electrocautery. Now let's compare the electrocautery with the laser. As regards the effectiveness are the same. The safety, almost the same. However, the cost it differs for the electrocautery. It's much cheaper. So this will let the electrocautery wins in this comparison. Electrocautery, unlike cryotherapy, can affect rapid debulking of the tumor in some cases, and it may be a reasonable modality to relieve impending respiratory failure if laser therapy or surgery is unavailable or inappropriate. Similar to cryo, some fibrotic lesions seem to be resistant to electrocautery. But unlike cryotherapy, electrocautery cannot be used for removal of foreign body or mucus plugs. Cryo can. And let's compare electrocautery with the cryotherapy. As regards the cost, almost the same. The safety, the cryotherapy is much safer than that of the electrocautery, and so in this part, the cryotherapy wins. However, if we added the effectiveness The electrocautery, of course, wins in comparing to cryotherapy. The advantage of electrocautery includes the immediate results, the rapid resection of the tumor, and the low risk of hemorrhage. However, the disadvantage is not useful for sessile or flat lesions, the excessive production of smoke, risk of electrocoagulation for the patient and the operator unless grounded bronchoscope is used, and risk of fire with high oxygen concentration. This is very important. In the bronchial electrocautery, its complications, as I mentioned, it's fire. However, I want to tell you that it is usually well tolerated, although there have been a number of complications published. To my knowledge, 2 endobronchial fires have been reported during the electrocautery procedure. Both were associated with high inspired oxygen concentration, and in one, a silicone stent ignited. I got the 3rd electrical fire I experienced myself. Let's see it. It's not working, huh? Okay. Okay, this is a patient with a stent here, and I ignited the electrocautery, but somehow away from the set, looked at the fire here. Unfortunately, the anesthetologist didn't reduce the oxygen during this procedure. It was horrible. I didn't know what to do. So I thought about injecting saline by the suction channel inside the fire, and it was fortunately successful. Stent, of course, was removed, and I found only charring of the bronchial tree. That was, bronchial toilet was proceeded, and the patient is fine now. So let's go back to the literature. Several investigators have reported hemorrhage in most cases which were minor. Operator and the patient burns, electrical shock are mentioned frequently as possible complications. However, published data are scant. Perforation pneumothorax and aspiration pneumonia were recorded in electrocautery. Another concern involves the use of electrocautery in patients with pacemaker or an automatic implantable defibrillator because the devices may malfunction and cause dysrhythmia. The outcomes of electrocautery: the hemoptysis was controlled in 75% of cases, dyspnea was alleviated in 67%, and cough stridor was relieved in 55%. Success is defined as removing more than 50% of the tumor. Success rates of 70 to 95% have been reported. In conclusion, bronchoscopic electrotherapy is proved to be effective and safe. It is cost effective as compared to other interventional procedure, and its use through the flexible bronchoscope makes electrocoagulation a favorable technique in both elective and emergency cases. And final advice is to keep the inspired oxygen below or equal to 40%. Please do it. Lastly, I want to show the last video to us to calm you for the electrotherapy. Yeah? It will work now? No. No. This is a case of post-intubation tracheal whip. This is the rare finding post-intubation. We found it in a girl. She refuses surgery. So we started cauterization of the whip. Of course, while cauterization oxygen here was decreased to below 40%. So starting cauterization all sides. To the right and to the left side. So we could pass the telescope to visualize the airway. Here's the airways, normal airways with no difficulty. This is the final post-cautery view. And the patient, we applied after that mitomycin to the lesion. We didn't apply stent. Fortunately, the patient responded to the mitomycin and there is no recurrent stenosis to this patient. Thank you very much.
Thank you, Dr. Ahmed, for a nice presentation. You did highlight the advantages of electrocautery as regard the effectiveness, cost, and feasibility in our area. Apart from the fire you have experienced and you were lucky enough to control. I'm honored to call for Professor Mo'min Wahidi. He will talk us about stenting for malignant endobronchial lesions.
Good afternoon. I'm going to talk to you about airway stenting specifically for malignant disease. Just a little bit of history about the word stent. Where did it come from? It was actually the name of Dr. Charles Stent, who's a British dentist, who in the 1800s created this dental compound that was used to support tissue. And then his last name stuck to that tool and actually was used by a plastic surgeon in 1916 in facial reconstruction surgery, and then later was adapted into kind of this plastic structure to support the airway. So stent is actually somebody's last name. Airway stents play a significant role in the treatment of central airway obstruction. It's the treatment of choice for patients with extrinsic compression of the airways. It can be used in conjunction with other treatments of endobronchial disease, such as laser, electrocautery, and can lead to immediate symptomatic improvement. Just kind of a reminder of the types of lesions we see in the airways, and you can see type A is the endoluminal disease, type B is the extrinsic compression, and type C is kind of the mixed disease. Stents really work best in type B when there's extrinsic compression. In type C, you probably use combined modalities where you remove the endobronchial disease, again with heat therapy such as laser or electrocautery, then supplement that with a stent placement to relieve the extrinsic compression. So the indications for stenting is, the indications are alleviation of extrinsic compression of the airways. If there's luminal narrowing due to mixed disease, as I just showed you in that C example, Benign airway disease, I'm not going to discuss too much in this talk because this is a malignant disease talk. And then management of airway fistula. I think the main thing to think about when we do therapeutic bronchoscopy is really we're trying to help patients with lung cancer. And as you all know, we have an epidemic of lung cancer because of smoking. It's an unfortunate fact that about a third of patients with lung cancer will develop complications associated with central airway obstruction and will present with symptoms like dyspnea, hemoptysis, atelectasis, collapse, and post-obstructive pneumonia. And even more sad is that about 35% of lung cancer patients die from local intrathoracic complications, such as terminal hemorrhage or asphyxiation. And our goal when we do these procedures is to alleviate these symptoms and hopefully prolong their lives. The major cause of malignant airway obstruction is lung cancer, obviously, but there are other cancers that like to metastasize to the airway, especially, this is in order actually of frequency in the airway, renal cell carcinoma, breast, thyroid, colon, melanoma, and of course lymphadenopathy that are adjacent to the airway. So these are all cancers that you may encounter in the airways. So just a few cases, few examples to show you. This is non-small cell lung cancer in the left mainstem bronchus. This is renal cell carcinoma. And I showed this yesterday. It was esophageal cancer compressing the trachea almost to a slit like lumen, causing stridor and respiratory failure, and then a stent is placed. A great example of how a stent can lead to immediate symptomatic improvement and open the trachea. So now I'm going to talk about the types of stents we have. This is kind of an illustration that a lot of people use. There's been a lot of stents on the market. A lot of them have been taken off the market due to problems in the stents. But what we left with are the metallic stents, which are covered or uncovered, and I'll show you that. Silicone stents, hybrid stents that have both silicone and metallic elements. And then under investigations now, we have drug-eluting stents with the hope of decreasing granulation tissue formation, and bioabsorbable stents, so stents that can be absorbed and gotten rid of so problems won't arise in the future. Those are still investigational. Let's start with metallic stents. Metallic stents are made of nitinol, which is actually two metals, nickel and titanium. It's an alloy of these two metals. And actually, this was a metal used in the military a lot, and it was adopted into medicine. It comes into two varieties, uncovered and then partially covered. So they couldn't cover the entire stent. It's partially covered because the sides of the stents, the metallic stents, are uncovered. And at least in the US, Ultraflex is a type that is used most. Nitinol is a very interesting metal and has temperature property. And so at colder temperature, it's actually compressed. And that's how they're able to compress it and put it on a deployer, which I'll show you. And in body temperature, it actually expands and opens up. And that's why when you put the stent first, you wait a little bit on it, a day or so, and expands actually nicely because of the shape memory that that metal has and the temperature property. This is the typical deployer, the deployment mechanism of the metallic stent. It comes again compressed because they do this under cold temperature, and then they wrap this thread around it. And when you want to deploy it, you just pull that thread, and you can see it deploying here as the thread is pulled away. This is kind of partial deployment. And as long as you're into that phase, you can still adjust the stent. You can pull it back. But once you have full deployment, manipulation of the stent has to be done with the forceps, and it can be a little challenging. How do you place metallic stents? You can put it with flexible bronchoscopy, where you put a wire through the scope, take the scope out, put the stent over the wire, and then put the scope through the vocal cords again and deploy the stent under direct visualization. You can see here the stent is near the scope, adjacent to the scope. You can do it under fluoroscopy because the stent has these radio-opaque markers, so you can do that. Or you can do it with rigid bronchoscopy under direct visualization. And this is an example of a metallic stent placement during rigid bronchoscopy, where you have a flexible scope through the rigid scope, and you're watching the deployment of the stent, and you can still adjust here the deployer. You can move it in and out. Now the stent is deployed and it's in place. So the advantages of metallic stents are they don't require rigid bronchoscopy. They definitely have a lower migration rate than other stents. They have this open meshwork design, which allows mucociliary drainage, so there's less impaction of mucus and mucoid plugs in the stents. And they have this really nice radial force. And so they conforms very well to tight, irregular stenoses. So they're the kind of stent of choice when it's a very tight, irregular stenosis. The disadvantages are, of course, it's a mesh, so tumor can grow through them and lead to obstruction. They really gradually become epithelialized within the bronchial wall. That means that you can't remove them after a while. So that's a major problem if you want to remove the stent, as I'll show you later. They're very expensive. In the United States, they cost $1,500 per stent. And they degrade over time, and they can fracture and cause problems in the airways. And of course, the uncovered ones are not suitable for fistula, most fistulas at least. Let's switch to silicone stents, which are tubes made of silicone. They have studs on the outside to reduce migration. They come in different sizes, and you can actually take a scalpel, cut them, make them shorter. It's common for us to modify them in the operating room. You can also make holes in them if you're trying to make a hole for a right upper lobe, for instance, if you put a right main stem bronchial stent. There's also a variation of that. It's the Y stent, which has a tracheal arm and 2 arms for the main stem bronchi. This is optimal for tumor that involves the main carina, or if you have diffuse malignant disease involving trachea and main stem bronchi, or also in Malaysia where you have diffuse excessive dynamic collapse. So advantages of silicone stent, they don't have a mesh, so they don't let tumor in. They're easy to place and reposition. You can fold them, remove them, reposition them as much as you can. The metallic stent, you can't do that. Once it's deployed, you can only pull them back, and you cannot remove them. Once you remove them, they're done. This you can remove and redeploy. They can be customized. There are some holes that we made for the right upper lobe, and they can be removed at any time. And then the cost in the United States for a silicone stent is $500, about a third of the cost of the metallic stent. The disadvantage, again, because of their tubular shape, they have a higher migration rate than metallic stents. They interfere with clearance of secretions. They enhance granulation tissue a little more than metallic, and they don't conform as well to irregular airways. But this is the biggest advantage, is that they can be removed very easily. And this movie is not working. Let me see. At the end of the talk, I'm not going to interrupt it. I'll show you that movie, how we can remove the silicone stent very easily. There's hybrid stents, and there are 2 kinds available. The polyflex stent, which is made of silicone membrane and a woven polyester mesh around it. And this requires rigid bronchoscopy. It has this special deployment structures. Again, very easy to remove. This has not done very well in the United States because of high rate of migration and fracture, and it's very rarely used today. A newer hybrid stent is a stent that has metallic elements and a polyurethane covers. And so it really combines both stents property. It was approved to be used in 2007. It's very easy to remove, and I'll show you some data on it. It's still kind of relatively new, so we don't have a lot of data on it. So just a word about a complication of stents. It's estimated that stents complication can be anywhere from 4 to 7%. The incidence varies based on the type of disease you're treating. But you can have migration, stent fracture, erosion, perforation into the airways, mucus impaction, infection, tumor ingrowth, and formation of granulation tissue. So how do you select silicone versus metallic? You have to look at the disease process. I'll mention something about benign disease. Metallic stents are not recommended for benign disease unless it's a last resort because of the difficulty in removal in the granulation tissue, and I'll show you some example. If extrinsic compression or intrinsic obstruction in the bronchial disease, you have to decide what kind of treatment you're doing. Are you going to need brachytherapy in the future? And that affects whether you want it covered or not. Whether it's a very complex or simple stenosis, sometimes it's hard to put silicone stents if it's a very complex stenosis. Again, permanent versus temporary, because the metallic stent, you cannot remove them after a specific period of time. And then also you want to look at, does your stent obstruct other airways, such as upper lobe, and that you may have to do a silicone stent and create a window. There's really no difference in efficacy clinically. They both work well in malignant disease. So this is metal stent disaster. So somebody placed a metallic stent in a trachea for a benign disease in Malaysia, and this is a year after. You can barely recognize the trachea. This is all fractured stent, unraveling wires. Patients have severe problems with dyspnea, and this, our attempt to remove it of about 2-3 hours, piece by piece, which is dangerous, and you don't want to do that if you can avoid placing metallic stents in patients that may live longer than a few months. The FDA in the United States issued this warning advising physicians not to place metallic stents in any benign tracheal disease because of this problem. And now this is a favorite issue for lawyers in the United States to sue doctors who place metallic stent in the trachea. So this is something we stop doing unless it's a last resort and in very specialized hands. Just a few slides on stent outcomes. Do they work? We don't have really randomized controlled trials. We have few prospective studies. One of them by Cavalier, who placed a lot of silicone stents. This is for silicone. He placed over 393 silicone stents in 306 patients. There was improvement in symptoms in almost all patients. Median survival was over 3 months. There was stent migration in 5% of patients, and overall complication rate of 9%. Hybrid stent, initially there was problems with them. They're migrating, they're buckling in. They recently improved them. There's now new data showing that they work better. This is data in lung transplant from University of Florida, and 49 stents. FEV1 improved, and complications, whoops, I have 2 more minutes. Thank you. And they performed well with, an acceptable rate of complication. And this is a recent study that I found from 2010, and I'm including it because I think it looked at data and looked at it in a scientific way. This is a retrospective study, but it's 72 stents over a 2-year period, and that's mixed types of stents, metallic and silicone. And they stratified the patients based on their ECOG performance status. So looking at the patients, how are they doing performance-wise, and seeing if stents help them or not. And they also looked at survival. And I think this is the first time we see survival data, although it's retrospective. And you see that the performance status improved in almost all patients, 90% of the patients. But what's impressive is the survival was better in patients who had somewhat of a moderate performance status, meaning if the patient had really poor performance status, it was too late. Sometimes we have to ask ourselves that question: if the patient with lung cancer, stage 4, have a really poor performance status, you may not be able to help them. Clearly, the ones that were helped here were the ones that had some decent functional status, and that was improved with stent placement. Just a couple slides. There's some issues about if you put a stent, do you do surveillance bronchoscopy? Do you bring the patient every 3 months, 6 months? There's actually one study by Dr. Colt who suggests that no. He followed patients with stents and they did not need routine bronchoscopy. It didn't help the patients. And the recommendation is that you do bronchoscopy on patients with stents only if they have symptoms, no symptoms, shortness of breath, cough, infection. And then this is also, nobody knows, if you put a silicone stent, they're prone to mucus plugging. Any regimen to decrease that problem, there's really no clear guidelines. People have used hypertonic saline and acetylcysteine nebulized treatment and bronchodilator. We use a combination of these, and everybody seems to have their own personal preference. So in summary, central air obstruction from cancer can be a significant problem with significant morbidity and mortality. Therapeutic bronchoscopy, specifically airway stenting, can really help the patient improve their quality of life and potentially extend their survival, as I showed you in that study, in patients who have some moderate functional status. But with the caveat is that the ideal stent does not yet exist. We have a lot of problems with the current stents, from migration to fractures, and so we need to work more and work on an ideal stent that doesn't migrate, doesn't cause granulation tissue, it's easily replaceable, and it's cheap. So I'm not very hopeful, but I think we're going to keep trying. So thank you for your attention.
Thank you, Professor Mu'min Wahidi, and for interesting lectures about stent and different modalities of it. At the end of session, we are very thankful for the chairman, the professor, and the doctor, and thank you very much.
I think that we have to start the next session because we are behind the schedule. But before starting the next session and the call for Professor Adil Khattab and Professor Gamal Rabia, I just got a message from Novartis company that all of the attendees of this session are invited to a symposium at the Grand Hyatt directly after this session, and the symposium is going to be followed by lunch at 4 o'clock. So please, after the session, just nearby here, the Grand Hyatt, and we are looking for your attendance in the Grand Hyatt.